Okay, well, welcome. So in this video, we're going to be talking about rationing scarce resources in healthcare, with a special focus on the biggest moment in rationing resources in recent memory, which would, of course, be the COVID-19 pandemic. So within this course, we're thinking about rationing resources as part of one of the four principles of medical ethics. Along with beneficence, autonomy, and non-maleficence, we can also think about ethics in healthcare in terms of justice, right? So we want to make sure that we are promoting justice in the decisions that we make, and that we are working within and working towards institutional arrangements that are just. Now, it's important when we think about justice to notice that justice is going to mean many different things in different contexts. So for instance, sometimes we talk about justice in terms of giving people what they deserve. That might be in terms of how hard they've worked. So we might say, look, the harder you work, the more money you earn. It might also just be you deserve a certain amount of wage for an honest day's work, right? You can also think about what people deserve in terms of what's sometimes called retributive justice. So there we'd be thinking about things like rewards and punishments. So one idea within retributive justice is this idea of an eye for an eye. Well, an eye for an eye thinking is one version of, a controversial version of, this idea of giving people what they deserve. We can also sometimes talk about justice as fair application of the law. So making sure that two people who commit the same crime, for instance, get the same punishment, or that certain laws aren't enacted unequally only on certain people. Right? So we might also think about justice in terms of treating people equally. Now, we might ask what kind of equality we're talking about. For instance, some philosophers think about equality of opportunity, some think about equality of outcome. Utilitarian philosophers will, for instance, say that everybody's pain and suffering and pleasure and happiness all count for the same thing. We might talk about the non-violation of others' rights. We might talk about abolishing socially created inequities. And we might also think about distributing resources in a way that is fair, equitable, or justified. So, for instance, the philosopher John Rawls, Rawls up on my shelf here. Here's Rawls. This philosopher John Rawls tells us, for instance, that a just society is one that distributes opportunities and offices of power in a way that makes them equally accessible to all, and that inequalities are only tolerable insofar as they do something to make the worst off as well off as they can be. So that's Rawls's famous difference principle, that if there's going to be differences in society, those differences have to be doing something good for the least well off within the society. So these are a bunch of different ways of thinking about justice. And certainly within the context of healthcare, we can think a lot about distributing resources in these fair, equitable, or justified ways. So think about rationing resources within healthcare. When we're thinking about rationing, what we're really talking about is having a system of limiting the amount of something someone is allowed to have. Right? So a ration system for food basically says everybody's going to get a certain set amount of some good. This happened during wartime, for instance, that in the Second World War, you would get a certain ration of flour and butter for each day. Now, rationing can be much broader than that and entail much different things. So, for instance, it might be a matter of, figuring out how much access to healthcare you get, which places get hospitals, how many nurses we're going to have in those hospitals, how many ICU beds that hospital will have. Right? We can notice that in any system of healthcare, resources are going to have to be rationed. And that's just a reality that basically comes out of the fact that we do not have infinite resources. Now, even in the United States healthcare system, which is privatized, there is rationing within the US healthcare system. We do not have infinite resources here in America. And in fact, a method that says some people are going to get more access to healthcare on the basis of their ability to pay, well, that's a form of rationing too. Now, just to get us into the topic a moment more, we can realize that the COVID-19 pandemic involved many cases where resources needed to be rationed. So for instance, N95 masks, ventilators, ICU beds, and vaccines were all things that we had limited amounts of, and we had to make policy decisions about how to distribute these resources. So in this video, what I want to do with you is look at two philosophers' perspectives on how to deal with these rationing decisions. So the first thinker we're going to be looking at, not only a public health policy expert, but also a medical doctor, Ezekiel Emanuel, and his co-authors wrote an essay about the fair allocation of scarce resources within the COVID-19 pandemic. Now, he suggests that when we ration, we're going to have to follow four core values. We want to maximize our benefits with scarce resources. We want to treat people equally. We want to promote and reward instrumental value. And we want priority for the worst off. Now, maybe just to speak a little bit to this idea of promoting and rewarding instrumental value, this is going to be the idea that we are going to promote policies that help us solve problems further down the road. When we talk about something being instrumentally valuable, we're talking about it as being good for getting other things that we care about. So for instance, money is instrumentally valuable for the stuff that it helps you buy, like food or concert tickets. Right? Now, when we think about promoting and rewarding instrumental value in terms of healthcare rationing, we can be thinking about things like making sure that healthcare workers are kept safe and healthy. Or it might also be a matter of giving extra benefits for patients who participate in things like studies on vaccines. Right? Now, Emanuel is claiming here that you cannot necessarily always promote all of these values all of the time, because sometimes treating people equally, that is, like giving two people with a similar diagnosis the same treatment, well, that might actually not maximize benefits with scarce resources. If, for instance, one person needed half the time on a ventilator than the other did, because then you can move that ventilator onto another person. So how does Emanuel deal with the situation? Well, he says that we should give one of these principles priority. So his suggestion is when we have to make rationing decisions, if we get a conflict, our first priority should be to maximize benefits. And here's the argument that he makes in favor of this claim. He says, maximizing benefits, this value, reflects the importance of responsible stewardship of resources. Stewardship just being taking care of something well. It's difficult to justify asking healthcare workers and the public to take risks and make sacrifices if the promise that their efforts will save and lengthen lives is illusory. So, if, for instance, we're throwing resources away, for instance, if we are failing to save lives by giving extra consideration to these other values, like helping out people who are worse off, Emanuel says that's going to be a way of losing the willingness of healthcare workers. We can't justify asking them to take risks if their work doesn't come to anything. So that seems to be the argument, and that seems to be Emanuel's argument in favor of maximizing benefits with scarce resources. Now, within these four values and giving priority to maximizing benefit, a manual also gives us some subsidiary policies. So to reward instrumental value, we'll prioritize healthcare workers. He in fact says that we don't want first come, first serve policies, that would be promoting perhaps treating people equal or priority for those who are there first. He's going to say that that's not going to maximize benefit. So if you have a more needy patient get to the emergency room second, they should get the care. Moreover, he thinks that there should be a lottery for patients who are in the same situation. That would be treating people equally. And the thought there is not only will that be fair, but it will also prevent, say, like people mobbing a hospital or possible violence. Now, Emmanuel says, one policy that we need to consider is taking patients off of ventilators and giving them to people who need them more. So the thought here is, look, if the needs of the hospital change and they realize that they'd be more likely to save a life if they moved a ventilator to another person, then they need to take it from the one patient and give it to the other. And part of doing this well would be a matter of informing patients that just because you've been given a ventilator doesn't necessarily mean that you're going to be able to keep it. He suggests responsiveness to research and evidence, so do what works and update your policies. Give tiebreak priority to research subjects. Again, that's a reward of instrumental value. And don't discriminate between COVID and non-COVID patients in distributing something like a ventilator. So if you've got, say, somebody going into anaphylactic shock, it's not COVID, but if they need a ventilator, they need a ventilator. And at this point, we should be just trying to save as much life as we can. So that's the gist of the Emmanuel policy, or the Emmanuel proposal, which is going to be that we want to do the thing that does the most good. And in some cases, that might mean doing things that are not very comfortable to do, like taking one patient off of a ventilator to maybe save a patient with a better prognosis, or, for instance, to give it to patients with a better chance of more quality years of life ahead of them. Now, let's look at another perspective. Maybe we can get a sense of this other perspective just from the title. So Angela Ballantine has an essay called How Many Lives or Whose Lives? So within her framework, Ballantine is seeing a conflict between utility, and utility is basically aiming for the best possible result, that is the best overall outcome. And she thinks that that can sometimes come into conflict with what she calls equity. So how could utility and equity come into conflict? Well, we can understand this partly by understanding what we're talking about when we talk about health equity. As she quotes it from the World Health Organization, health equity is all about preventing remediable differences among groups of people, whether those groups are defined socially, economically, or demographically. So, for instance, it is a remediable difference here in the United States that the black infant mortality rate is much higher than the infant mortality rate for the rest of the population, right? We would think that if we set up our systems better, we could remediate that problem, right? So that would be an instance of inequity, and Ballantine is thinking that we don't just want to save as much life as we can, but we also have to think about whose lives we're saving. And we don't want a situation where the deaths from a COVID-19 pandemic, for instance, are especially burdensome for historically disadvantaged groups. So she's arguing against the assumption that we should save as many lives as possible, irrespective of whose lives are saved, because she thinks that we could have inequities if we did so. So just to continue, oftentimes what we're going to do, if we're just trying to save as much life as we can, is we're going to base that on prognosis, right? Don't give a ventilator to one person who's going to need it for a week if you could give it to to people who are only going to need it for 3 or 4 days each, right? And give the ventilator to somebody who has a really good chance of having their lives saved, rather than somebody who's a little more chancy. Ballantyne's problem with this approach is that if you base rations on prognosis, that can reinforce health inequities for some social groups. Ballantyne is a philosopher working out of New Zealand, and she notices that the indigenous people of New Zealand, the Maori people, they have higher rates of multimorbidities. So that's 2 or 3 or 4 indicators that you might have a bad health outcome if you come down with something like COVID-19. Right? So indicators of a morbidity, a comorbidity would be things like hypertension, pulmonary disease, diabetes, and so forth. Now, the thought here is that if you have more people with multimorbidities in the Maori population, and if people with multimorbidities are less likely to get ventilators, then it would seem that we're going to give less ventilator access to a historically disadvantaged group, the Maori people in this case. Now, Ballantyne points out that public interest requires the responsible use of resources. So she agrees with Emmanuel that we're asking a lot of our healthcare workers and the public. But here's her point of disagreement. She's going to say that responsible use of resources does not exclusively entail maximizing utility. There's public interest in reaffirming human rights, the value of diversity, promoting fairness, and resisting entrenched privilege. So Ballantyne's thought is you can oppose wasting resources, but you can still believe that some patients with a worse prognosis still deserve a shot at life-saving treatment. So simply plugging in a bunch of comorbidities to an algorithm, that might unfairly leave some people behind. And this is why Ballantyne would argue against this perspective that we just saw from Emmanuel, which basically says, when it comes down to it, we should focus less on treating people equally and focus more on treating people in a way that maximizes utility. Ballantyne says, actually, treating people equally and dealing with health inequities is going to be a hugely important thing and something that we can't let go of, even in a situation like a pandemic. So this leaves us with some questions, right? When it comes to scarce resources, we're going to have scarcity sometimes. What should have we done through the COVID-19 pandemic? Did it make sense to, say, factor in age or prognosis into whether we treat a person? Should we be focused on whether the patient is part of a socially marginalized group? Should we be thinking about whether people participated in research or whether they refused to get a vaccine? More concernedly, we might worry about whether we should be factoring in things like usefulness to society, right? Should doctors and teachers and lawyers get priority over, say, tradespeople? Many people find that repugnant. So we would have to think about what sorts of policies we'd want to enact. Should we give maximizing lives saved as our clear first and guiding principle? And if we take Ballantyne's suggestion of maximizing equity, how are we going to do it? So I'll leave you with those thoughts. Thanks for listening in, and take care.